Good morning, folks. We are still waiting on folks to join, and so we'll get started in a couple of minutes. While we wait, please feel free to review our housekeeping reminders on the slide, and we'll begin shortly. Good morning. I see more folks joining. Welcome. We'll get started in 1 or 2 minutes. Thank you all for joining. Good morning, folks. It still seems like people are joining, so I'm going to give it another minute before we get started. Okay, it seems like folks joining has slowed down, and I know we had some TEP members who are going to be joining late. So I will go ahead and get us started. Welcome, everyone, to our last meeting of the Artificial Intelligence Technical Expert Panel. We had a very engaging discussion on Monday, and we look forward to continuing and finalizing a review of public comment received on the draft AI report during today's meeting. We appreciate the TEP's participation and commitment to these meetings and review of public comments, especially given the significant time we're asking of you this week and time we asked of you over the holidays. We've identified several key topics for discussion today, and we really look forward to your insights. The purpose of today's meeting is to finalize our discussions of the public comments so that we can prepare the final version of the report. The topics we have chosen to focus on today are continuing our discussion from Monday on allowing measured entities to select their own AI method, reevaluating recommendations related to gaming, incorporating human in the loop processes, addressing the risk of hallucinations, promoting interoperability and the use of standard data standards, refining details in the AI model summary label, and also including a future considerations section. We've saved some time at the end of the meeting to have an open discussion on any additional TEP feedback you have, and then we'll close by quickly discussing next steps. So, as previously mentioned, our meeting objectives are to discuss public comments received on the draft report, summarizing TEP recommendations for developing, selecting, and implementing AI-enabled quality measures, and seek input from the TEP on areas of the report and public comments received that need additional discussion prior to final publication of the report. Before we move on to the roll call, are there any questions about the objectives or what we plan to cover today?
Yes, can I ask a quick clarifying question maybe on the overall report?
Sure, go ahead, Paul.
So thank you for this meeting objectives. So probably point one is what it'd be interesting to help us. You've done a great job teeing up the questions. These are gnarly topics in AI, and the use of AI and quality measurement. But it would help us as we go through these questions. Remind us, what are the objectives of the report? Who's the audience? What actions would you like to see from them? And what's NQS role going forward? I think that would help set the context for how we provide feedback.
Yeah, those are great questions, Paul. Happy to speak to that. So first, the objectives of the report and who's the audience. So I would say that we have four main types of audiences for the report. Those would be our key actors. I mean, we are outlining recommendations for them, and so they are certainly key members of our audience. And as you may remember, we really said the primary audience would be program owners, but certainly the recommendations and the report we would hope would be useful to measure developers, measured entities, and measure implementation vendors as well. As far as actions we'd like to see, I mean, we are putting out a set of recommendations. At the moment, we don't have a mechanism for ensuring that these recommendations are met, and that's one reason why we wanted to include program owners as a key audience member and a key actor because we think that they can have some leverage to make sure these recommendations are implemented, but there are other entities that could be interested in this as well, like the consensus-based entity and others. And as far as NQF's role moving forward, unfortunately I don't have a specific answer for that right now. I think we'll have to see what NQF's role is going to be. We don't have immediate plans. The funding for this from Gordon and Betty Moore Foundation does we're sort of wrapping up that particular grant with this work. So we'd have to see what we'd be able to do in this space moving forward. I do see that Elizabeth's on though. So Elizabeth, is there anything you'd add?
Yeah, sure. So in terms of a formal follow-on to this work, Jana's spoken to that. I would just add that we're very active as an organization in this space in the sense that our senior, staff and leaders participate in national discussions about quality measurement and their governance and implementation and advancement in a number of fora across, contribute for example, the current consensus-based entity, Battelle, and their convenings, and our work with CMS and others. And then in addition, we're an affiliate of the Joint Commission, and both NQF and the Joint Commission develop and steward measures and are engaged in programs that implement measures. So will be a user of the guidance and a tester, and hopefully demonstrating its implementation in those contexts. So in those different wearing those across those different activities and capacities, we will be actively engaged with AI-enabled quality measurement.
Thanks for those answers. Is there someone who would specifically be the adjudicator of whether your recommendations are followed in the quality measure definitions?
That's a good question. I mean, there is a CMS funded consensus-based entity, Battelle, which runs a process. They're actively engaged and following this project and commented on it. They run a process of endorsing measures and a second process of supporting CMS in gathering public input on measures they propose. and in for use in, CMS's 25 plus regulatory programs. So it's more federally focused and draws input in from all different types of stakeholders. In that context, both CMS and Battelle said these recommendations are important to them in thinking about how they'll structure and consider the use of AI and quality measures going forward. And CMS is the biggest program owner we have. So but there are many contexts in which these issues are coming up. Anywhere we're implementing, AI-enabled measures, electronic clinical quality measures that have AI or even just NLP components, we're grappling with those issues. But yeah, I'd say that there's other, maybe Danielle could speak to this. There's a core quality measure collaborative, which is a alliance of payers that work to get to standardized measure sets to lower burden and foster more aligned, efficient implementation focused on the best measure sets. That's another forum that's been grappling with some of these questions that can help move the implementation forward. And others on this call are engaged at various levels in their own spaces.
Wonderful. Thank you so much.
Thanks for asking the question, Paul. Okay, why don't we go ahead and move on to roll call then? So Emma, I'll hand it off to you.
Yeah, thanks, Jenna. I'll run through our roster here on the slide, and as I call your name, if you could indicate whether you're present, that would be great. I'll start with Monica.
Present.
Chandra,
Present.
Robert,
Here.
Mark. Actually, don't see Mark on yet, and Rebecca is unable to join us today, so I'll skip to Laura.
Present.
Rosemary,
Present.
and then ZQ is going to be joining the later part of today's meeting, so I'll skip to Charlotta.
Present.
Vincent,
Present.
thank you. And I don't think Danielle is able to join us today either, so I'll skip to Yuan. Don't see him on. And John is also going to be joining the later part of today's meeting, so skip to Eric. I also don't see on yet, so Paul,
Here.
Megan,
Present.
and Ben.
Present.
Great, thank you all. Is there anyone I didn't call on or anyone that joined late that I missed? If not, we can move on to the next slide. So as with our previous TEP meetings, we may have liaisons listening on to today's call, and you can see them all here listed on the slide. And we may also have advisory group members from our Advancing Measurement on Diagnostic Excellence initiative, which this project is a part of, who will also be listening in. And with that, I'll pass it back to Jenna to review our meeting ground rules.
Thank you so much, Emma. And because most of you were here on Monday, and I think you as a group are familiar with our meeting ground rules, I'm really just going to highlight that if you could please use the raise hand function, which you all were doing so well on Monday, to make sure we can involve everyone in discussion. And again, I think we're really trying to build consensus here. So for the most part, we're asking you to contribute verbally rather than adding to the chat. So that's it. We can go ahead and get started. We have a lot of ground to cover today, and we're looking forward to a great discussion. We are starting with the topic we ended with on Monday. We ran out of time, so we're going to circle back to that, and that is about allowing measured entities to select their own AI method. Since some of you weren't in attendance on Monday, and because I covered it, I introduced it pretty quickly, I'm going to spend a bit more time providing a brief summary of the public comments we received on this topic before we open the conversation. So as a reminder, we received 18 comments indicating mixed feedback on allowing measured entities flexibility to select their own AI method across 18 unique submissions. This was definitely a topic where we got a lot of feedback. For those in favor of flexibility, one professional society argued that flexibility enables entities to account for local differences. One healthcare technology organization suggested that local tuning is already a method of substitution or flexibility, and it would be inconsistent to allow tuning but not substitution. This same organization suggested that AI models quickly become outdated, so flexibility is important for entities to maintain the latest model. A professional society suggested that rigid requirements may disadvantage certain resource-limited entities. And finally, the healthcare technology organization I mentioned earlier also recommended that flexibility could reduce burden on measured developers and measured entities, as vendors could be the ones to manage updates to substitute methods. Those who were not in favor of flexibilities, we heard from one health IT interoperability vendor and an individual commenter who suggested that substitution undermines consistency, comparability, and fairness. Similarly, one patient safety organization noted that adherence to one method ensures consistency, reliability, and validity. This same patient safety organization noted that substitution adds complexity for users and can complicate data aggregation. The same individual contributor I mentioned before noted that adjustments in AI methods may alter performance, distort bias detection, and compromise equity. And then one government policy group cautioned that flexibility may conflict with current statutory frameworks that rely on standardized measures for payment and public reporting. We go to the next slide, then we also heard from some who supported flexibility, but only if certain conditions are met. We received 10 comments related to this across 10 unique submissions. So one professional society suggested flexibility should be allowed only if the substitute method proves equivalent results to the measure's original method. One patient, caregiver, and family advocacy group suggested patients must be informed about changes to the AI method. This same group also recommended that if flexibility is allowed, monitoring must be transparent. One group providing direct care and one health IT interoperability vendor suggested that any changes to the AI method must be clearly justified and documented. One patient safety organization suggested that any changes must follow the 5-step roadmap outlined in the report. Two professional societies recommended that any changes to the AI method must align with the measure developer's specification and the measure's intent. The health IT interoperability vendor mentioned earlier suggested that the substitute method must meet established performance thresholds. A professional society suggested that the substitute method must undergo rigorous validation and reassessment against reference data standards, and an individual commenter noted that alternate methods should only be used if it does not alter the model's logic, weights, or predictive relationships. Finally, one professional consulting service for payers, direct care, and government agencies suggested that substitute methods must undergo formal audit to verify data authenticity and establish parameters for monitoring. So if we go to the next slide, considering the public comments we received and your own expertise, we'd like to revisit this question of whether the TEP agrees or disagrees with allowing measured entities to select their own AI method. I'm going to stop at that question. We have some additional ones, but I think let's start with that one. And again, this is because there are very different opinions amongst the TEP. This is a reason why we have this particular topic in our emerging topics section. So we'll see where the discussion goes today. And see if there seems to be any more consensus building amongst the TEP or if there's still differences of opinions here. And I see some hands raised already, so I'll go to Charlotta first.
Yes. So I think like working in this field of AI, I think it would be very, very hard to like not allow any flexibility. I just don't know that that would be feasible. I just because healthcare systems may have access to slightly infrastructure. The infrastructure is changing. I mean, even the models and the technology is like rapidly evolving. And that's again, I know I've said this like many times, but I really am in favor of having like some like assessment against a reference data set. I know that's very complicated, but at least having each user implementation site show that whatever they are using is producing, like is valid. Um, yeah, I just think like having no flexibility would be, I don't see how that would work, actually, like from my perspective. Like then a lot would be on the measure developer to constantly update the methods or yeah, that's just my thoughts.
Great. Thank you, Charlotta. Monica, go to you next.
Yeah, so I think one thing I was thinking about since our last meeting was like a concrete example, and I think one could be like something that's like relatively simple, but I think is used in a lot of measures is like admission time because you need to like often there's a lot of measures that are a function of like did X happen within Y time of admission. And for some hospitals, admission time lives in like a note, and for some places it's like in an observation table, and for some places it's in a flow sheet. And one, I don't think it's like fair to the measure developer to have to like imagine every place something could occur. Because even if they look at 3 or 4 different hospitals, maybe by chance, and you imagine if the scale's to like 10 variables you need to keep track of, you might not see every instantiation at, the set of 3 you develop over. So for something that I think is, really benign, which is admission time, it would just be really difficult to have one algorithm that worked everywhere. And I don't think it's necessarily like lacking consistency because, if you looked for admission time in a flow sheet and another place didn't use a flow sheet, then you're sort of, stuck because you just can't get the variable you need. So I think at least and I think this, echoes back to, if you have a small institution and you keep data in some certain way, it's probably not, if you know where your admission time is, it's probably faster to do manual chart review admission time than to like build an algorithm to extract admission time. Um, I think this, maybe ties into the human in the loop component that came up later, which is like maybe for the smaller institutions, there's certain fields that are fast for them to like fill out by hand, and other ones where AI could be helpful because it's like, finding some sort of past medical history or something that's like always found in a note. But I think allowing places to choose when would just be, I think as Charlotta said, it's really hard to imagine building an algorithm that works at every single institution. Now, I think when we talk about predictive AI, the story changes because if everyone has a different underlying algorithm for something predictive, I think the sets of questions change versus, something extractive. But I think to have that discussion, maybe one thing that would be useful, and probably is out of scope, is having a concrete example of a predictive algorithm we would want to use for quality measures. Because I think we've mostly talked about extractive measures in the examples we've sort of seen so far.
Thank you so much, Monica. Those are helpful points. Vinny, I'll go to you next.
Yeah, I think I'll just quickly say that I agree. And especially as I think into the future, we're going to be using things like LLMs, I think with much increased frequency. I mean, just the fact that, LLMs are different, they continue to evolve. Different health systems may have access to different ones. And so I think if we don't kind of skate to where the puck is going, this guidance will become outdated. I do think the regulatory consideration, making sure everybody's on a level playing field and that we feel that the measurement is accurate and fair across the different entities. I mean, that will be a real struggle, but at the same time, I mean, the field is changing, and I don't think we can ignore kind of where we're going to be and where we are already with technology enhancements.
Great. Think you so much. Paul.
Yeah, I'm gonna just because you're asking what's the TEP feeling today. I'm gonna second the 3 previous comments. I think Charlotta brought up the key thing, which is it really feasible to ask people to have a prescriptive definition and not allow any flexibility? then I really like Monica's example of admission time, which is simple yet can be pivotal in terms of the score you calculate, or even something like smoking history. We all have different places where we put that local to the organization. So we can't really have a prescriptive place either prescribed by the measured developer or implemented by the measured entity. And then what Vinny said is the fairness. I mean, I think it's the trust but verify kind of a thing. We obviously have to be able to go into audit to see how they did it, but as long as it's a reliable approach, it's no different from any other structured data element in the quality measure definition. So going back to my first question of what's the purpose, who's the audience, who's going to act? If you say we're giving advice to future program owners, like CMS, the biggest, then I think this recommendation of prescriptive versus not and flexibility is a key recommendation coming out of the report, which is why I think so many people are weighing in on it. And so I'll just add to the previous comments.
Great. Thank you so much, Paul. I will also, I'm going to caution us. I think we are missing the key voices who in the past in previous discussions have expressed concerns with allowing a lot of flexibility. Specifically, I think at the moment, we're missing Danielle, ZQ, and John Martin. So all of those, I think we're going to hear our conversation go a certain way, I'm guessing. But I do want to recognize that the folks who've expressed the most concern are not here. So I'm going to try to speak for them right now just to let folks know that. But Megan, I'll go to you next.
Thanks. As predicted, I am just going to weigh in favor of flexibility, just to make the point that I think the other TEP members have already made. That if the goal is fairness, I actually don't think that rigid, completely uniform methods will achieve fairness because the same approaches are not and resources are not available at every health system. And every health system needs to do this fine tuning because there's different documentation practices, as Monica has already described really well with her concrete example. And even sometimes it's not even as different as like, where does this variable live? But it can be as minor as like small changes in the way that the language they use to document. So maybe they describe a condition in a certain way at one institution versus the other, and that might change your approach to prompting or searching for specific characteristics. So I think if our goal is to create fairness and an even playing field, I actually do not think that a very rigid and prescriptive approach will achieve that.
Thank you, Megan. Rosemary.
Yes, I won't repeat everything that everybody said, but you're asking for the expert panel feedback, and I support flexibility. The models are changing, that actually we need to be careful. We could actually do more harm and move away from the science of the measure if we didn't provide that kind of flexibility.
Thank you. John is actually here. So John, I'm sorry. I hope I didn't put words in your mouth. I'll let you go next.
No, I joined literally right after you said that. So, or before you said that. So when it comes to flexibility, I mean, to be fair, I mean, I understand the reason for it, and I understand the need to reduce burden, and there is need for an organization to evaluate how they're doing. And if they're using the model internally and for internal purposes, I don't have any concerns with that. Where I become concerned is where we're evaluating providers over time or against each other for payment purposes, for example, and we're allowing them to use different models, different methodologies in their evaluation. That's where my concern comes in. And I do understand, yes, we are going to have, if that's the case, then we're going to have to set some sort of limits and parameters around that evaluation and measure. If we're saying that the text extraction has to be up to X level performance, then that's what we need to say. And whether you're using this model or that, and that maybe that's where flexibility can come in. But we have to be very careful on saying, oh yes, we're just going to be chasing this model updates all the time. we've been doing that for decades. I mean, models have improved over decades, maybe not at the leaps and bounds we're seeing today, but we've had to come up with ways of setting thresholds for that over the last however long. And so while I see, yes, our improvements in use of AI and new models are coming out just constantly, that doesn't mean that we should change our expectations for how they perform. So I guess that's where I'll stop. Thanks.
Thank you, John. Ben.
Yeah, I was going to say, I second John's concern that any benchmark used for any quality measure used for national benchmarking, flexibility is really going to be a problem there. It leads to variability in the way that the measure is going to be aggregated or calculated. And that may make some sense at the local level for local improvement. That's probably best practice, but at the national level, that's really going to cause difficulty with this. I also would disagree with Megan's statement that flexibility would increase, or sorry, would improve the or reduce disparities in measurement. I feel like certain organizations are going to have a lot of resources and tech and talent in order to optimize if we allow flexibility, but other organizations are really going to kind of take what's out of the box and not have the resources to optimize it, and they will perform less well, presumably.
That seemed to prompt some more more hands. So Robert, I'll go to you next.
Yeah, I mean, this is not directly related to Ben's comment, but I guess in my head, I'm trying to, especially as we're talking about extractive AI, I'm trying to think of our current state where we are using, quality measures which involve often human chart review to pull out parts of the, measures or metrics or whatever. And the question, I guess, is how much flexibility currently lives in the human chart review process for measures? And I don't know the complete answer. I'm not 100% in this world, but because I think that's kind of the analogy in my mind is like how much flexibility do we give human extractors right now versus what we're talking about as AI enhanced extraction? Because I think if I just talking to some of our quality folks, sometimes there is some, judgment involved in, what are we using to pull out certain elements of our performance data and that type of thing. So I just feel like that is sort of at least where my head was going. But for me, like not the philosophical part, but just the practical part, I don't see how we can avoid flexibility. And maybe the recommendation is that now is not the time to make accountability measures based on this if we can't get rid of the fact that we can't feasibly do it in a way that is consistent across all organizations.
Thank you, Robert. I also curious how folks feel about Robert's last comment as far as recommending that we don't use measures for accountability this time, given where we are in the state of the field. But Laura, I'll go to you next.
Thanks, Jenna. I am in the flexibility camp, but I'd love to hear from the folks that were raising concerns. If we could maybe walk through a specific example and just get really, really technical about how this works for a second. I think I need to bring it into specifics to have more clarity. Can we do that?
Yeah, I think that's a good idea. I don't know, Megan, you've got your hand raised. I don't know if you feel comfortable giving an example and then speaking to your point, or if someone else
I
would
don't
like
know
to.
if I don't know if I sh I think I'll let others maybe weigh in with a concrete example. I agree completely, Laura, that an example may help ground us. I think I wanted to raise a question that may be answered by walking through an example. I think I completely hear the comments and concerns from those who are against flexibility because I totally agree with that in theory. I guess my question to the TEP is if we don't allow flexibility, then what? Does that mean that to Robert's point, maybe we just don't endorse the use of AI in quality measures at this time? Does that mean that we encourage, for example, the example that Ben gave of different health systems having different capabilities? So if some health systems are able to fine tune a model and others have to use quote out of the box, does that mean we just recommend everybody use out of the box for fairness and equity? how do we handle the point that Monica brought up around data living in different spots in the EHR if we're not allowing flexibility? I guess that's my question to the TEP that may be raised through a concrete example if someone else has one.
Great. Oh, go ahead, John.
Yeah, I'm sorry. Next in line. So I'm jumping in too soon. So I think that on the flexibility answer, to answer, I guess, Megan, what you just talked about, for me, we have the ability now, and I agree, right? On the data we collected in the past, who's to say how good that was collected by individual extractors and how consistent that was? But today, with NLP and other text extraction methodologies that we have the opportunity to actually provide some standards around, okay, we would expect it to perform at this level, and we can test that now much easier than if we had to do it by human. So that's where I see the opportunity coming in here, is that we at least show that we have some sort of consistency in extraction of elements, whatever it might be. I mean, I think even it's maybe a bad example. I mean, I years ago worked in clinical trials, and we had to calibrate our lab values, right? Everybody had to look at the calibration of their lab values to make sure there was consistency in how the lab values are reported out. I don't think this is that much different in that we're just expecting that if you're going to use one model, it needs to at least have a certain level of performance and consistent extraction so that when we use a measure, that measure will be, the evaluation will be, I guess, relevant, and the performance of that measure is realistic given that we don't have the variability in what was extracted from the text. I don't know if that helps at all, but to me, that's kind of where I'm thinking. And if we can't do that, then I have problems with using the text extraction. It's relatively new. I know it's pervasive, but it's still relatively new. And there are different systems, and I know that each one of them performs differently. So I'd like to see something like that. If all of our organizations that we work with, for example, are going to be evaluated across the country in a comparative fashion, I want to know that what's being pulled out and evaluated is similar and consistent.
Great. Thank you, John. Okay. I do want to make sure we provide an example or two to ground the rest of the discussion. And we're already, I think this is where we were supposed to shift in the agenda to a new topic, but this is so central to our discussion. I think we need to spend time here. So Chandra, Charlotta, or Robert, are you raising your hands to give an example?
I can give an example, which is like where, what we do, and at Dana-Farber and through the ADCC, we're looking at documentation of goals of care and discussions around hospice for patients with a prognosis of in the last 6 months of life. And I think in that case, responding to John's, so it's very much text-based. It's extremely cumbersome to do that manually. It's like very, very difficult. And we actually find that human chart review is worse than NLP or LLM because humans just, it's like such a cumbersome task that it's like difficult to even have the concentration and things are missed, or it's also extremely expensive to train humans to do the chart extraction. So it's very expensive. There's actually a lot of variability even after a lot of training. And we actually have at Dana-Farber, we have this in our payer program. So we're reporting these numbers to the payers, pay for performance. So we see a lot of variability among the humans, and with NLP, and now we're starting using LLM, there is less variability. And I think to John's point, I think each healthcare system, when they go to implement, that the measure would have like a toolkit, like this is how you're going to implement this, and you will have to do some manual review and then compare the manual review to, the NLP or LLM approach and kind of show how it differs or how it's similar, and that there is a performance, some performance metrics from that comparison. So I do think it makes sense that in the implementation that there would be like the site would like document how it was implemented and what their testing, showed. And that's where I also love having like some kind of some kind of reference data set. And also, like when we do this with the payers, we actually pull out examples of documentations. Like if we would get audited, we have like examples of documentations like de-identified that the LLM pulled to say this is what we counted as like meeting the criteria. So we keep track over time. And also I think these like tools when it comes to LLM, they also change and update. And so you actually need to have like a healthcare system and a measure will have to have a process to reevaluate the performance and to document the performance before because the technology is changing over time.
Great. Thanks, Charlotta. So before we go back to the discussion, this is so helpful and appreciate you giving an example. Does that concrete example help? Any questions about the example? Okay. I'm going to assume that no hands means that your example was helpful, Charlotta, and clear to folks. So thank you again for that. There were some hands raised before. I don't know. I think it was Chandra, Charlotta, Megan. Were there others? Did those folks want to go ahead and raise your hands for discussion? I didn't mean to interrupt people's thoughts before.
I ended up putting my comment
All
in the
right.
chat, just thinking that we were
Okay.
moving on. But it was really just related to the reference standard idea. Even sort of a standard data set of notes or text-based thing, it's not 100% clear to me how standard that really is from site to site, given sort of differences across organizations. So it just, I know we can't sort of be perfect and we shouldn't expect to be perfect, but it still sort of raises questions to me about um, how we standardize the performance across different sites if we allow, for LLM based extraction.
So I'm gonna try to summarize some of where I think we are at the moment and then welcome you all to react to this. So, at first, as far as current state goes, as we're pointing out, even with human abstraction, um, you're not necessarily going to, first, human abstractors are going to abstract like those are each individual people. So they are, while they're following a measure specification, there's going to be some variability there. I guess I don't know if folks happen to know the answer to this, and I'm sure it varies by program, but for chart abstracted measures, are there requirements from program owners around something like inter-rater reliability? Is that checked more through audit? And again, I know audits vary across programs as well. And Heidi, our consultants on Heidi, I don't know if you have, um, if you can speak to that at all. And see a Danielle on, that might be Danielle Lloyd. If that's you, I don't know if you can speak to that at all. I'm just trying to also, I said I was going to summarize where I think we are, but I'm actually wanted to try to summarize what I think the current state is, and then I'll get to what I think I'm hearing from folks. But yeah, does anyone happen to know with current state and human abstraction what the requirements are?
So, Jenna, if Danielle has more too, I'm just trying to think for CMS programs, there the the only thing I can think of is there are audits that are required and they have to demonstrate that what they said they submitted is indeed what is in the medical record. But I don't know that I've ever seen requirements around hitting a specific inner rater reliability or anything, I do think that would satisfy most likely if it was audited. For HEDIS, I think it's a very similar process. It's more reliant on the audit and that the audit results actually demonstrate that what was specified in the measure that they said they provided matches. I don't know that anyone would be against providing parameters, but I think it would be interesting to see if a developer thought that that would be feasible or not. I don't think it's a bad thing, but I don't know how easy it would be. But welcome thoughts from others.
Yeah, it's Danielle. I would just say, it is something that leaves much to be desired in the current system, and sort of our hope is that with AI we might be able to improve upon that. But as Heidi said, it's not like there's a thorough systematic system where we assess inter-rater reliability and make adjustments based on it or anything like that, right? You would catch some of that in audits, but clearly there's been research that it is an issue with the existing chart-based measures, but we don't have like a great system now where we would have to say, oh, the AI system has to meet that, right, or match that.
Great. Thanks, Danielle. Okay, that's what I thought. So I hope having that current state in mind is helpful. Charlotta, I'll come to you next. And then Monica.
Yes, I just wanted to add that that's what we do at Dana-Farber. They told me, because I'm in charge of these like NLP assisted quality measurements for the payers, that we should assume with every report, like every 3 months, that we have documentation if there would be an audit to kind of show that what we are identifying as like a goals of care conversation, that we can like provide that information. And again, that's where we pull examples and they're completely de-identified. We have actually never been in an audit like ever but we have all of that like documentation. And I think actually that is like really important for the leadership of the program to be able to also see that there is like consistency in what's being identified over time. So I think that's a great idea. And then again, we run regularly test examples to make sure that we generate the same results. That's what we do as a internal quality control.
Yeah. Okay. Thanks, Charlotta. And before I come to you, Monica, I'd also like to introduce a point that an audit, for example, might look different, and I don't know how this could look different too. If you're trying to prove something did happen, if you're trying to show evidence that something did happen that you're saying happened, those would be things that you typically want to happen, versus you're trying to show evidence that something didn't happen that you don't want to have happened, like a negative outcome, right? So again, that there might be some implications for that too. Again, I'm going to summarize where I think we are, but I want to let Monica go first.
I think super quick, I just wanted to give an example. I threw a paper in the chat that I actually found from UCSD's SEP1 registry paper when I was reading through that. And I just thought this was cool. I don't think this happens super often, but this was this thing where they did 3 different sites and had them all do. So I think this is a CMS SEP1 measure, is my understanding, for sepsis. And they just found that there was huge variability there was pretty low agreement in determining time 0 for sepsis between different sites. So I just thought that was a useful data point that was asked for earlier.
Great. Thanks, Monica. Yeah, we've talked about that example a little bit before as well, but not in detail. And yes, I think that is a helpful example. So again, Paul, go ahead. I don't want to get ahead of folks.
I'm trying to break the stalemate here. I wonder, we're getting into this problem because we're focusing in on so-called process quality measures. And if we move towards outcomes, we're going to have less of this problem. So I wonder if this is even a nice point to be pointing that out, in the sense of, shouldn't our quality measures be going more towards outcomes anyway? And these fights over how we define things, which really mostly affect the process measures, will make that less of an impact.
Well, I'd like you to say more about that. And then also have others react, because this is what I was just getting. I would actually think that there would potentially be a lot more concern if you were trying to use different AI methods to identify outcomes, and you'd want to prove even more that you are actually identifying the outcomes that are in the measure, because again, I think that people would be even more sensitive to the fact that if you use a different method, you might not identify any outcomes.
Okay, so
And proving that something didn't happen, I think is, providing the evidence that something didn't happen is harder than providing evidence that something did happen.
Okay, so what we're trying to do, so the outcomes I'm talking about are things like death, heart attack, stroke, amputation. These are the outcomes that matter to the patient. The time to the sepsis time or the treatment of pneumonia time really impacts, well, what's the outcome of having pneumonia? So we want to look, those things are not as subject to gaming. The process measures are more subject to gaming. Does that help, Jenna?
Yeah, I'm just not sure I agree.
Okay,
Um,
that's fine. Yeah.
Actually, we've been talking about outcome measures this past week, and I've been hearing feedback from hospitals about how they are subject to gaming. So I don't know that they are. And
No,
yeah,
I'll retract that
yeah.
statement because there's so much, but the outcomes are less deniable, like death or heart attack.
Yeah.
Elizabeth, go ahead.
Yeah, this is hard, and I really appreciate the conversation. Yeah, on that last point, just quickly, I do agree that outcomes, because all our outcomes like mortality, eased in accountability programs adjust for differences in case mix. So it requires pulling forward, conditions that were present on arrival and a lot of other detailed clinical data. So we don't escape that, unfortunately. I wanted to go back to the characterization of the current state, and I think it's been helpful for us to talk about it and just maybe broaden out, because that is our starting point. And as several of you said, including Danielle, it's not ideal. We not only for chart abstracted measures, but for ECQMs, we do have variability in what data gets pulled forward that goes into measure score calculations, whether those are processes or outcomes. And that process of pulling the data, whether it's out of the EHR, through a electronic pull or audit, is we allow that variability. And we're exploiting technology now to pull from more data sources, like on measures that are hard, like, are you up to date on your colorectal cancer screening, which is, if you're using colonoscopy, a once in 10-year event. So we're already in this space where systems have differential ability to get the best data for the measure score calculation, and we're using multiple technologies. And I just, that is our current state. And I want us to, I think we all have the intent of wanting to be able to use AI-enabled measures and data extraction processes both to get to lower burden, more high fidelity measures. So I just wanted to flag that and maybe separate, maybe we need to, we're noting here, we're talking about in some ways assembling the data used in the calculation. That's a little different from your example, Charlotta, where you're reading records and you're making inferences. That's very NLP, that's a big add in terms of the inferences we're making, not just the sources of where we're pulling data, say from a flow sheet or, this part in the medical record or that part. How can we sharpen what we're saying a little bit about just calling out that, there's a data pull and that's enabled by some AI technologies. And then there's a measure score calculation. Both of those steps are important, and can be AI enabled. That's my first point. And then second, the current state does allow for that flexibility. Vendors don't have to implement the ECQM software that, is packaged and formally tested. They can vary off that software, whether you're CERN or Epic or whatever, and install the measure in the way that works best in the system you're in, right? We don't require digital measures to be implemented consistently. So we tolerate that. And I guess that's And we do some, some organizations do audits, some do by attestation. Like looking at how well are we doing that at the Joint Commission, we're on the ground looking at data quality and supporting and giving feedback to hospitals on that, on measures that they report either through chart abstraction or ECQMs. How can we move from the current state to where we want to go safely, and contextualize it, well from this conversation? And I'll just stop there and turn it back over to you guys to, try to bring this to closure.
Robert, go to you, and then I do want to try to summarize what I think I'm hearing, both so we can move on and so that I can try to capture what I think I'm hearing, at least, so that we as a team can write this up in the right way in the report. But Robert,
I
I'll
just
go
had a
to
clarifying question
yeah.
for Elizabeth. I guess you're giving the example of like, not sort of there's NLP to kind of make inferences about the text, and then there's assembling the data for the measure calculations. I guess I'm trying to figure out like if it's not extracting out of NLP and it's just like assembling the data, where would the AI part of it come in? If it's just like assigning the flow sheet or whichever sort of concrete place that it lives, I can imagine NLP, like the example that was given about did a goals of care conversation occur? That would require either there's a structured place and then you don't need
Yeah.
AI, or it's in the free text style and you do need NLP at least or something like that. So I'm just trying to figure out exactly that distinction just to make sure that I understand where you want the conversation to go.
Yeah, there's two pieces to it. I don't mean to complicate the conversation, but one is sort of what data sources you're pulling for, like in the NCQA HEDIS measures, you might pull off of EHRs and claims, and supplement with some chart abstracted data to get all the information to inform the measure logic. Like, did this person have a visit for depression and were they screened? There's endless examples of these measures, or if it's a risk adjusted measure, to pull as much as you can about their risk factors to, the higher the risk factors, usually for mortality, for example, you're going to have a better adjusted measure score if you pull all of those in. So one of it is just being able to span those sources and pull data in efficiently. And so technologies that help you read and process, whether it's EHR data and not miss anything, or claims, assist with that. And then your second part was, but the difference, I mean, the difference about pulling, NLP is very straightforward. I'm not sure I can describe how AI enabled technologies can really help you better pull, like what we were talking about back at the beginning. What was the, admission time or the presentation time, something like that, that is in a couple sources might be coded in a different ways. I think technology can help us get that right more consistently, and across more types of more diverse systems that store things in different ways as well.
Okay, so let me summarize where I think we are and also bring in where, what we have in the report as a reminder. So in the report, we talk quite a bit about allowing for tuning and what needs to happen as a result of tuning being allowed. In our testing section, for example, we talk about the performance standards that need to be set by the measure developer, and saying that the program owner and measure developer and measured entity, all four of the key actors, are responsible for making sure measured entities are meeting the performance standards that are set as they tune the measure. I think where we stopped short of some of the recommendations from TEP members is saying not only can they tune, but they can just use whichever AI method they want. And that is now in the emerging topics section, as well as the use of reference data sets or third-party validators. I think based on where we are in the discussion today, and with the report, it still feels appropriate to me to have this discussion about allowing for any type of AI method that a measured entity wants to use being in emerging topics. I think you all have introduced some additional points today that we can really use to flesh out that section nicely. But to me, it feels like it's still contentious and something that will need further discussion, because of the issue that in order to really make sure that that the scores are comparable, we might need some systems in place that need to be developed. We might need some infrastructure, and it might mean, for example, it could be more audit than we currently do, or it could mean having reference data sets, which again don't really exist. So that's, I think, what I would recommend is leaving the structure of the report the same and just bringing forward more of the points that you all have raised and really reflecting this incredibly rich discussion and the complexities on both sides. How does the TEP feel about that? Concerns with approaching it that way?
I guess I like most of what you said, but I think you're still coming down on presenting a prescriptive approach to including AI in your quality measure definition. And that I think is not where the majority of us lie. I think Elizabeth did a wonderful job saying, hey, this flexibility argument, I'm not sure where that comes from because all of the measures virtually have already existed. We'd love to have something more standardized, but that's just not possible. It never has been possible, and it's not possible now. Why would we all of a sudden, when we use the word AI, force it into the discussion? I may have gotten your nuance wrong, Jenna, but that's what I hear is let's keep the prescriptive nature and we'll explain it more. And I think this is a key recommendation that we sort of have to help decide, help weigh in on.
Thanks, Paul. Laura, I'm going to let others react to that before I jump in. Laura, if you're speaking, I think you're on mute.
Thanks. I appreciate what you said, what Paul said as well. I think a couple things. I think we still need to be really clear about if we're talking about AI for measure development or AI for data extraction or AI for clinical decision support, where I think we've gotten comments from different perspectives coming into this mix, and be really clear about what we mean there. The other thing that we were talking about on Monday that got me thinking was, the inequity of health systems being able to adopt. There's always sort of an advantage and a disadvantage to being an early adopter of anything. You might get the advantages out of it, but you also put in the time and the effort and the cost. So we'll be seeing a good bit of that, but we've also recommended testing, tuning, oversight, governance, and additional things around patient engagement and safety, which I think kind of help buffer this as an early adopter phase of using AI. So I'm starting to feel more comfortable. I don't know if that helps other people or not, but that's kind of how I'm looking at it. We just need to have more parameters around this.
Thank you, Laura. And to your first question, I mean, I think mostly what we've talked about is AI being used for data collection in some way, identifying data that can be used in the measure. To Elizabeth's point, we don't have a clear example really of AI being used to then take those data points and calculate a measure score. So I think that's the safest model to have in our head, or like that's the most concrete model we can have in our head. I know that once we start thinking about things that are theoretical, but we don't have a concrete example, it makes it harder for us to think about the recommendations. But yeah, at the moment, we are not talking about AI that would be helping to make treatment decisions or, clinical decision support. So I just wanted to clarify that. If anyone disagrees with that, please let me know. But that's what I have in my mind, at least. Danielle.
Yeah. So, I mean, I guess I have a fundamentally different position on this, because as I've articulated, right, the payers are not going to want to see that level of variability because, in moving sort of existing types of measures, whether charter claims or whatever, to some of these measures where they're include components that are AI based, we're going to want to see sort of the AI based versus today. And if we then have also, it's not exactly inter-rater reliability. Like, yes, we have well, you guys know what I'm trying to say. It's not coming out today. Inter-rater reliability. There we go. But now we also want to interject inter-method variability. Like, that's going to make it worse. And so I think introducing even more moving pieces where we don't know what's a difference in performance versus a difference in how you're pulling the data and implementing the measure I think it's something at the end of the day, we could put that in the paper, but I can guarantee you payers are not going to let that happen. It's just not, it's not a reasonable ask in a system where you're trying to compare different organizations. So I'm far more comfortable with the approach of this is something that we need to be thinking about in the future. And at some point we might want to get there, but we have a whole lot more research to do on how these measures are going to work in practical reality before we can get there.
I guess, Danielle, most of us are asking if you could provide your response to Elizabeth, who's saying it's already variable. What's different? How are you dealing with it now? You're saying we won't be able to deal with it in the future. How are you dealing with the variability now?
And I will confess I'm driving. So hear all of what Elizabeth said. However, I think I got the gist of it. But yes, there's variability today, but not adding extra variability doesn't help. Right?
Yeah.
So
I think that frame, Danielle,
it's
is
like double downing.
yeah, I think it's an important one. So and I agree with your articulation that we could be adding more. It's another variable if the NLP, algorithm is changed and maybe it in tuned, right? But we are saying, as I think it was Laura said, but apologies if I got that wrong, we are putting other, guardrails around the use of this kind of technology in the report. We are calling for that. So I'm wondering, Jenna, in part, if we're using the word flexibility, it's just, allow flexibility or not is to like it means different things to different people. Maybe we might consider reframing to say, acknowledge first of all that the current system isn't perfect, and we have some efforts to try to make sure ECQMs and chart obstructive measures are done similar ways. But there's, some variation allowed, particularly in ECQMs. And the concern is we're adding potentially more room for variation, but we also want to allow the use of technology. But we can acknowledge the concern, I think, and we're making as a group, or the TEP is making, I take myself out of that because we're really following your lead. We're recommending guardrails around that and monitoring and gaining experience. So I'm not sure the flexibility either or is maybe I'm wondering if the TEP members can respond to how we might shift our frame a little bit here, because I'm not sure there's big disagreement on the way forward. Maybe just
Well, I don't, yeah, Elizabeth, that's why I was saying like how I reframed it and how we actually talk about it in the report. I do think, so the way, as I was saying, I think what we leave in is the content we have around tuning, unless anyone strongly disagrees with that. What we have in emerging topics is them, for example, being allowed to choose their own AI method, like choosing a totally different method or model than the measure developer used. So that's the framing we have in the report. And I don't know that I'm hearing us moving away from that, but others can let me know if you agree or disagree. Yeah, we don't use the term flexibility in the report. Okay. We do have other topics to get to today, so I want to see if we can start getting to a point where we can move on, but I don't want to cut off discussion because, like I said, I think this is so central and it's something that came up in the comments quite a bit. And I think it's going to be one of the big concerns that people have about using AI and accountability measures in particular. So, not trying to cut you off, but we'll start trying to move us onto other topics. But Megan, go ahead.
Yeah, thanks. I maybe this can hopefully help to summarize and move us on. I think we're all actually in agreement that there shouldn't be a lower bar for AI. Like certainly we would expect for there to be comparable results. And we can do that by, for example, saying whether you're using an NLP based approach or an LLM based approach, you still have to compare against a human benchmark and you still have to provide something like an F score or something like that to show it doesn't have to be that specific score, but like something like that would be producible across methods. So I think what perhaps as you summarize in the paper, it's about the disagreement is really focused on how much flexibility, maybe not we're using the word flexibility, how much do we allow different methods, but not saying that we are lowering the bar in any way for AI derived components, compared to the current standard. In fact, by measuring against a human benchmark, which is what's typical, you are not doing that. So I think your proposal for summarizing it is reasonable.
Thanks, Megan. I will say, I think one thing that we've heard mentioned before, and I think it's already reflected in the report, I think we have a comment about this, is that with AI, we do expect that perhaps the human benchmark will be worse than the AI, like with the SEP1 example, the sepsis bundle. So I think we did want to acknowledge that. Monica.
I think the quick thing that we might want to reference with sort of this discussion, and I know this is already in emerging topics, is sort of the thing about whether the code is shared. Because I think, like if there's a standard method, but there's no associated code, and my understanding of the current recommendation is that like configuration is required, but the code isn't. Like, I do think it is hard to just do tuning, especially for anywhere that doesn't have, resources of a large academic institution.
Sorry, Monica, can you just say a little bit more about that? I want to make sure I'm following you.
Okay, so, and you can tell me if I misremembered or interpreted the current recommendation, which is that there has to be a configuration file, but potentially people wouldn't share code.
I think and I don't think I want to reopen this discussion
So
in this meeting. No,
potentially we
sorry.
can
No,
close
what I'm
it.
going to say next. No, what I'm going to say next is because again, I think under emerging topics, we also have the discussion of whether proprietary algorithms should be allowed or not. So that's the conversation I'm not sure if you want to open, and for
Got
that
it.
reason, that's why we're not requiring code because we are saying that and for some things, you won't have code, right? Like if you're using an LLM, you're not going to have, and it's not open source, you're not going to have access to the code. So I think that's why. So yes, I think you're right. And
Got it.
yeah,
I mean, I think we might not have access to the weights, but they would still have access to the code they use to
okay.
invoke the LLM. And maybe that's the difference we have to make, which is that there might be a proprietary thing under the hood. Um, but at least like there's some shareable way of like how you're invoking that. And I think that might go to the point about, LLM used in a purely extractive manner where it might be fine to have something proprietary under the hood versus if it's being used in some sort of combination, then we obviously have to know like what that combination is doing in I think an open manner. Kind of going back to the patient transparency bit. But I will not reopen this Pandora's box and
Appreciate those comments. So yeah, I'm not trying to cut off conversation. I just, like I said, we don't have proprietary algorithms on our agenda for today. So anyway, okay. Do we feel comfortable with where we are? I do see that there's still some chats coming in. We are planning to give the TEP an opportunity to see the report after we've made updates. I will say based on the amount of time we will have left at that point, it's really like for a red flag review, like there's something in it you really have an issue with or are concerned about. But we are going to give you an opportunity to see how we are taking all of your feedback and incorporating it into the report. So do we feel comfortable moving on to the next topic?
So do you want to summarize where you think we are now? What is it going to say about prescriptive AI methods?
Again, I think it's going to what I said before stands. The main reason being that one of the main reasons being that I think if we just say we're open to any type of AI method, it would require rewriting the entire report. Whereas if we can reflect this discussion in the emerging topics, I think it allows us to, and I'm not hearing enough consensus from the TEP that we should be like totally rewriting the report to say any method is allowed and here's how and that would look.
Would you want to, willing to take a vote on it? Because just like you said, I think it's central. That's the implication of it. We'd have to change the report. I don't think it's rewriting the report. I think it's really this prescriptive versus not, the same language surrounding it. The language surrounding it would, I think, be the same. It's just whether we come down in our recommendation to CMS that they have the prescribed approach, like like was in our example.
Yeah, and just a caution, I feel guilty in setting the stage in the wrong way, perhaps. I mean, this report is not a recommendation to CMS per se, right? It's a recommendation to all users. So I want to caution it'll be this committee's recommendation, for the broad approach of use of quality measures and accountability. Another thing we could do here, Paul, is to draft language and circulate it back
That would be
to
great.
try to reflect the richness of this conversation, because I think we can get closer to the the mix of opinions and balance the language, and have you guys look at it. And that, Jenna, what do you think about that as a next step?
Well, I think that would be in the report we send back. I don't know that we would get ahead of like sending this one thing out and not the whole report. So
Right. Sorry.
yeah,
I don't think we explained as a process next step that,
I just mentioned
yeah.
that a couple minutes ago.
Okay, great. Sorry.
So
Yeah, but you said it was a red flag only, and you also said this was the key conclusion or recommendation or advice. I
then
think
how
we ought to.
about we take this off, we allow the team to take it offline and discuss and come back to the TEP about what we think next steps would be. I do think that if the TEP really felt strongly that the framing we are using for the recommendations is that any AI method is allowed, it would require it would mean, for example, we'd need to look at every single strategy and every single recommendation that we've made, as well as the roadmap tables, and think about, do those look different with that framing in mind? That's why I'm like, that feels like a big change. Whereas if we leave it in the emerging topics and we reflect, like I said, the very rich conversation that's been had here, I'm cautious about taking that big of a step at this point. It is very important, and these recommendations are meant to be the TEP's recommendations. So I want you all to feel free to push back, but that's just where I am.
But
And
I
welcome your
think the way you
thoughts.
defined it as it's either use any method or have flexibility to achieve the same goals, that's very different. We're not saying any method. We have the same validation, the same monitoring, but we're not saying you can be prescriptive from 3 years ago, and that's the only way you can use this measure today. That's what we're saying. So I am reacting and pushing back on it's not any method. No, none of us said that. But we did describe it as more flexible. And that's why I think Elizabeth's suggestion that we sort of work on the wording would be very helpful, because telling us, hey, give us some red flag chance at the end, I don't think it's going to reflect the rich discussion we had today for an hour and 15 minutes.
Let me go to Robert and Danielle, see what some other TEP members think.
Yeah, I guess my question about it is, like, if it's local tuning is the level of flexibility that's being proposed, I'm not sure that fully addresses the challenges that we're saying about different organizations or different settings can have different capabilities. I think if we've gotten to a certain approach and it's just kind of local tuning of a certain approach, it does potentially put them into a box that raises the same kind of concerns about variable capabilities, variable resources, and that type of thing. So I guess that's maybe pushing that, like, we need a little bit more flexibility than just or local tuning would be, I guess, what I would think as well.
Thanks, Robert. Danielle?
Yeah, I think the other point, because clearly I'm in the other camp, is I don't think that this was clear that this level of flexibility would be permitted in the original document that went out for comments. And I know the various organizations I represent would have written comments to counter that had it been in there. So I do think that's something to keep in mind as well. As I've mentioned, the entire point of the Core Quality Measure Collaborative is to reduce and remove variability in measures and how measures are applied. And that's 75 organizations who would have written in to that effect. So I do think we need to be careful to not make fundamental changes while at the same time honoring and expressing that there are different opinions and that there is a push and pull that we're going to have to live with and have to navigate.
Thanks, Danielle. All right, how about this? So this is a method I like to use when we're getting to a point like this in a discussion. We did want to add in a break for today because we recognize this is a 3-hour meeting and we're doing it over pretty much everyone's lunch time, probably. So why don't we use this as an opportunity to take a 10-minute break? The team can reconvene and discuss what we could do to move this forward and come back with a proposal after the break. How does that sound? Okay. All right, seeing lots of thumbs up. So why don't we take a 10-minute break coming back at 12:32 Eastern time, and we'll see if we have it might just be that we need to spend more time offline and then come back to you all about it, but let's at least give the team a chance to discuss and then we will come back. So we'll see you at 12:32 Eastern. Thank you all so much. Extra minutes. All right, so I think we do have I think we have a solution that's going to incorporate the feedback and acknowledges what Danielle raised as well. So we will take the, again, very rich discussion that you all had today and reflect it in the body of the report. We'll try to be clearer about if if an entity is using a method not described or not used by the measure developer, here are the things, the considerations, really trying to also get across like why this matters. And you all will get an opportunity to see the report again. So that's our proposal for moving it forward. And Heidi, I don't know if there's anything else you want to add to that. But that's where we have landed.
Yeah, Jenna, I don't know. Apologies if you said this. But the team has talked about adding a future considerations section to this report as well, which I think we can build out all of the richness of this discussion, both through kind of a section on this alone, and then what the future considerations are. Also, whatever we decide we can integrate into the body of the report, particularly, I think, around the roadmap. So hopefully this is a good compromise to show how much time you all have tried to figure out where to land and show, I think we're not there yet. And I think hopefully in maybe a few years, this will be an easier conversation.
Thank you, Heidi. Okay. I think with that, we can move on then. Folks comfortable with that? See a couple, that sounds good in the chat. Okay, so we are going to have to adjust the rest of the agenda as well. I think what I'd like to do is go to the human in the loop section of our discussion, because I think that does flow from the discussion we're having now, or that we just had. And this topic, and I'll also say the hallucinations one, were things that I think the TEP mentioned, like it has come up in TEP conversation, but isn't explicitly referenced in the report at the moment. So given that those topics came up in public comment, we wanted to circle back to you all about those to see if you would want us to have an explicit, if we'd want to be mentioning those explicitly in the report. So um, sorry, before I move on, I do want to say thank you all very much. I know this was a tough conversation. Really appreciate that there are different perspectives, although I think we are all we all have the same goal here as far as and recognizing the AI does have an opportunity to improve measurement and reduce burden. So we definitely want to make sure that all of the nuance and considerations that you all are bringing up are reflected in the report, and just really appreciate you all sticking with us through that conversation and providing so many thoughtful comments on the topic. All right, so having said that, moving into the incorporating human in the loop processes. So we received 7 comments about this across 4 unique submissions related to strategy 5, prioritizing ongoing monitoring and maintenance. One professional society that's also a measure developer recommended conducting periodic manual audits on high stakes AI predictions to confirm clinician agreement and alignment with patient outcomes. We heard one individual commenter suggested that any AI-based metric used for accountability should include clinician oversight and human in the loop safeguards. One consensus-based entity noted that human in the loop processes, such as reviewing plausibility of AI outputs, helps maintain human decision making. A professional consulting service group for payers, direct care, and government agencies recommended integrating an AI data verification process that includes primary source resource traceability, AI modification logs, hallucination risk flags, and human oversight verifications. They did caution though that if human verification is skipped, maybe because a system doesn't have resources for that confidence scores would decrease. The same group recommended applying hallucination controls that include error detection mechanisms, human review thresholds for high-risk outputs, and user feedback loops to flag inaccuracies. A healthcare technology company recommended using human abstractors for monitoring by tracking acceptance rates through either accepting or modifying AI's predictions. The commenter said entities could track how often predictions are accepted to provide a signal of model accuracy and stability. The group also recommended running controlled withholding, or as another option, running controlled withholding experiments where AI suggestions are intentionally hidden from abstractors for a small random subset of questions. And in those cases, abstractors would provide results manually to create an unbiased reference data set to assess the model's ongoing accuracy. So I think we'll go to hallucinations specifically next. So we don't need to talk about hallucinations in this discussion, but does the TEP support the recommendation, or would you like to add something explicitly to the report about using human in the loop processes? And are there particular suggestions on the previous slide that you want to discuss, to add to the report, or that you have concerns about? Great. So Paul, start with you.
Hi. It's obviously our fallback position, and we certainly use this in, like, say, clinical decision support and other things in the clinical space. But unfortunately, from a cognitive psychology point of view, or even some studies that have been done literally about this, we quickly defer to the automation, to the computer. Quickly means like within the same day, within a couple examples. And so it may be a crutch that we just want to make sure that we don't over rely on it.
Great. Thank you, Paul. So I think, so you're cautioning that if we were to recommend it, you'd want to be careful about not over relying on it. Is that what you were saying? Sorry if I misunderstood.
It's known not to work. it's a good liability backup, but it's known not to work. And so we bring up, hey, here's one approach, but we just happen to know we can cite studies that it actually is not helpful because we quickly defer to the automation bias and just let the computer do its thing.
Okay, thank you. That helps clarify. All right, ZQ.
Yeah, I'm just thinking about, right, a lot of AI tool use the data and data, and I the minimum using some coding data. We know coding guidance change over year, and coding practice change, new code emerge. So that is not something AI will know right away. They may pick up at some point, but maybe a little bit too late, right? And and also because of you know clinical practice improve, right? You identify new treatment, new intervention. So what we call concept shift, right? The relationship between outcome and variable may be different after some improvement in how you care for patients. So I don't have specific idea how to specify the role of human, but I do think we need to have human in the loop. I mean, need to incorporate that. I mean, it's not just an abstractor, right? Because it's more than just abstractor. So I think it's important to include human in the loop.
Thank you. Others? I think we've heard one vote for including it, one as a caution about including it. What do others think? John. John, if you're speaking, you're on mute.
Am I off? I'm sorry, my
Yes.
computer froze for a moment.
Oh, no, that's okay. There you go.
Yeah, so I tend to be more in agreement with ZQ. I do think, in the process today, we already have a lot of human involvement, though. I guess I would like to know how this fits or would be beyond what we do today. Because we have a lot of review panels like this one. We have a lot of expert panels when measures are being developed to get input. Um, I I don't know. I mean, I just would like to see how the difference that we're talking about here.
Thanks, John. And in my interpretation of what's being recommended, it's more so like it would be something happening at the measured entity or implementation vendor level where they would be reviewing results, the outputs from the AI, and in some way, and having a human verify in some way. Again, and there's lots of different ways that that could happen. That's my interpretation, but welcome others to speak to that. Vinny, I'll go to you.
Yeah, I mean, I think this is important um, to the extent that these quality measures are being used, in kind of downstream applications. I think oversight is the right term because I think what we're finding in AI applications is the layer at which human oversight is needed varies by the application, right? Like there are some things in which a human should be in the loop in every decision, or even the output of some, Gen AI model, like the human has to edit every time. And then there are other processes in which the human is orchestrating or overseeing an orchestrated system in which the human is still in the loop, but does not have to specifically click on every decision or edit every decision. So, and so I think that I think being too prescriptive about, every output has to pass through the hands of a human is probably not realistic into the future. But the broad agreement, traceability, and then verification. I think this captures it pretty well for me.
Great, thank you. Laura.
Thanks. I agree with what everybody has said. I think, I want to emphasize at what stage in the process do we need oversight and by whom. So during development, I think of the measure, there's a stronger validation need when you're initial implementation, there's a validation need, but then on an ongoing basis, we get into an oversight need. And again, I agree with what people are saying that we don't want to make this too onerous. And I agree with what Paul's saying, like we're going to quickly come to realize that automation is kind of making this hopefully better than it should be. But I think the relative responsibilities of different entities are different, and they're different at different stages in the process.
Great. Thank you, Laura. Monica.
Yeah, so I think I agree with what was said about kind of oversight. So I agree with all of that. I think the one thing is confidence scores, I think can be tricky to sort of make numeric in the sense that it's like one example I like to use is if you're like trying to figure out if like a patient has diabetes and there might be like a question of like, oh, they have an A1C of something that would maybe indicate diabetes, but like what does a confidence score look like if they have an A1C of 8 or something, which you would think is so I just think like confidence scores as the way to do that might be a little tricky. So I just wouldn't want to mandate that. But I do think like some sort of traceability mechanism so you know what drove the extraction is useful.
Okay, great. So I'm hearing I'm hearing support for including and Chandra, I'll come to you next. But hearing some support for including some type of human in the loop oversight, but not being too prescriptive. Perhaps we don't mention confidence scores. Chandra.
I was just going to agree pretty much with everything everybody else has said about human oversight. I think it's important that we do consider it, especially as depending on the complexity of the scenario or the workflow. I think that will help with some of that also. So I totally agree with the group on making sure that we include that.
Great. Thank you. Um, all right. I think we have our direction here from the TEP. We'll add some language in the report about human in the loop. And again, you'll get a chance to see that. So why don't we go to hallucinations next? Because some of the comments that we received overlap between these two topics as well. So we received 9 comments related to addressing the risk of hallucinations across 6 unique submissions. Related to strategy 2, one healthcare technology organization suggested that multi-stage validation of underlying training and test data, any LLM or NLP processing engines and model outputs is crucial to establish baseline model behavior and monitor for drift and hallucinations. Related to strategy 5, one professional society suggested that unmonitored AI-derived components can lead to hallucinations, which can potentially result in misleading or inaccurate information. One measure developer and one government agency policy group suggested that hallucinations are particularly unpredictable and difficult to detect without careful examination of source data. One professional consulting service for payers, direct care, and government agencies suggested incorporating an AI data verification process that includes several capabilities, including hallucination risk flags. And the same group recommended applying hallucination controls that incorporate error detection mechanisms, human review thresholds, which we just talked about, and user feedback loops to flag inaccuracies. And the last comment is about flexibility. So I feel like we've already talked about that. So let's stay focused on hallucinations and go to the next slide. So again, I don't think we've specifically acknowledged hallucinations in the reports. We want to ask, do you want to address the risk of hallucinations? And then do you have specific recommendations above and beyond what we've already written in the report about testing and monitoring maintenance, but anything specific to hallucinations you'd like to recommend? And is there anything from the previous slide that you'd like to discuss as well? So I will start with ZQ.
So I actually have a question, right? So hallucination is just one potential issue. There are multiple potential issues. Why do we need to call it out specifically? Like, if we implement everything we propose, do you think that can be addressed already, right?
And that's a question for the TEP. Do you think that there's something unique about hallucinations that perhaps would not be caught by what we've already outlined in the report, or their specific, do you have any specific recommendations related to reducing the risk of hallucinations or addressing the risk of hallucinations that you think we need to mention? But I think that's a fair question, ZQ.
To me, that is as part of any measure due diligence, you need constantly evaluate data element, measure score, reliability, validity. You constantly check that, right? Even like to go back to coding, very simple. As coding evolve, sometimes new code emerge, some old code discard, and you see the difference. You have to sort of do annual update to make sure things are working as intended, right? So I agree with the importance of manage this. I'm just saying, do we need to call it out specifically?
Great, thank you. Welcome others to react to that. Paul, go to you.
I guess for the whole reasons that he mentioned, we should call it out. So common things that we look for in LLM use are omissions and hallucinations. And clearly, let's say the most common things common LLM-based application we use is ambient scribes, and there's tons of hallucinations going on that are not being noticed. Again, the human in the loop thing. And so I think I don't know why we wouldn't. So I looked through the report, did a search, and we didn't mention it even once. So I think we probably should include it because it is a risk. It will cause changes in the scores that are calculated. So hallucinations and omissions, which are common deficiencies in LLMs.
Thanks, Paul. So one in favor of mentioning explicitly, one not so sure. Chandra.
I agree with Paul. I think that it is definitely needed. And I was just thinking of some examples of where we have used them. For example, with we have contradictory data flags. We have alerts around pattern deviation. And so I think that, if we don't mention this, it's a possibility that it'll get missed. And so I definitely agree with Paul on this.
Thanks, Chandra. I think what I'm hearing so far, though, is that we mention it as a risk, but I don't hear anyone recommending anything. I don't think I do, unless Chandra, what you were just saying with the contradictory data flags or flags around pattern deviation is, what do others think about adding those in as mitigation strategies or ways to watch for hallucinations? John.
Yeah, I agree. I think with Paul and others that we should probably include it in there. I think it kind of fits with what we just talked about with the human in the loop as well, though. I mean, it could be added in some similar section that just to help with identification of hallucinations, while it may not catch everything. Human in the loop might be something that we should be using here.
Great, thank you, John. All right, seems like uh, we are mostly, folks speaking up, mostly in favor of adding, but does anyone else want to add any thoughts? Okay. Then let's move on to, let's see, if we can circle back to the gaming topic. All right, so we received 7 comments related to how gaming is framed in the report across 5 unique submissions. Several commenters expressed concerns related to how we've currently written them up in the report. One government policy group agreed that attention should be given to the potential of gaming, but cautioned that minimizing gaming is an impossible challenge, especially if a measure is used in multiple accountability programs. The group also noted the responsibility for gaming is unclear in cases where the measure developer and program owner are not the same entity, and further cautioned that local tuning could introduce gaming risks. For example, entities might compare tuned and untuned AI models and select the version that yields a better score. A healthcare technology company highlighted that it's important to frame AI's potential risks in the appropriate context. For instance, sophisticated AI-enabled measures are generally less vulnerable to gaming compared to ICD or rule-based methods. Without acknowledging current limitations around existing methods, we risk holding AI-enabled measures to a higher standard. However, if AI-enabled measures are designed correctly, they could be better than the status quo. We also heard two commenters suggested that the report should do more to address gaming. A professional society called for anti-gaming strategies for both measured entities and program owners. And a consensus-based entity recommended we include concrete examples of gaming scenarios and corresponding mitigation strategies, as this will help developers and program owners design AI-derived components that are resilient to manipulation. Go to the next slide. We also received 3 comments on how to reframe the current recommendations related to gaming across 3 unique submissions. Related to strategy 1, a professional society that is also a measure developer had concerns about and suggested that measure developers should not be responsible for designing measures to avoid the potential for gaming, as this is unfeasible and misallocates their responsibility. For strategy 2, a government policy group recommended that program owners should be responsible for setting standards to assess a measure for gaming, especially if it's used in an accountability program. For example, a program owner may establish that a specific program may require that key variables like clinical outcomes not be AI generated. And a patient, family, and caregiver advocacy group recommended that program owners should require local tuning be reported in a public summary and undergo periodic audit to preserve transparency and avoid gaming. So if we go to the next slide, some questions for you all is, are there any clarifications or additional guidance the TEP would like to provide related to gaming based on the public comments? Would the TEP like to modify or clarify the roles of measure developers and program owners related to preventing gaming? And then is there anything from the previous 2 slides you'd like to discuss or add to the report? And do you have any other recommendations you'd like to suggest for reducing the potential for gaming at this point? I know that was quite a few questions. I'll start by any reactions to the public comments, and does that change how you're thinking of the recommendations that are currently in the report? Start with you, ZQ.
I saw one comments about developers should not be paying attention to gaming. I thought that was a little bit too lenient. I mean they can be held responsible for gaming, but I think when they design a measure, they do need to keep that in mind, right? So if you set out a measure knowing that there are some really weakness, vulnerable area, or not addressing it, I just don't think it's appropriate. But I mean, obviously, there's no gaming proof measure, right? But I do think they need to pay attention. They need to work on that. And I sort of like coding, right? Your pneumonia may be my sepsis, so you need to keep that in mind when you using the code, right? So I think we do need to have reasonable ask for the developer to keep that in mind at minimum.
Thank you, ZQ. And I also will work on pulling up the recommendation specific to it and putting it in the chat, so you all have that in front of you in case you don't have the report in front of you right now. But I'll go to Paul next.
Yeah, I agree with that too. I was particularly offended by the fact that the measure developer thought they shouldn't be responsible. I think I like what the program owner said about setting standards for anti-gaming, because gaming sort of just undermines the entire reason or mission for quality measurement. And yet you can take steps to avoid it. And it occurs at every level. everything from the actual intent of the measure. So in one case, a professional organization said for cataract extraction, only consider those with no comorbidities. Well, the only people who get cataracts are people who are older. So it essentially created a measure that was always going to favor high scores, which was, I believe, part of the intent. So that's gaming can actually be coming in through the design. Then what Elizabeth mentioned about the precedent on admissions, there's tons of ways that people game that to sort of get out of the denominator, but we can be aware of that and talk about what measure developers, what kinds of data elements they should be using in order to avoid gaming. And it's much better to rely on clinical versus billing data as an example. So there's lots of examples in multiple steps, but I think it is part of what we want to do is concentrate on responsible development of quality measures. And it starts with the program owners, definitely goes to the measure developers.
Great, thank you, Paul. And I put in the chat the section that's specifically about what measure developers should do in the chat related to gaming, just so you have that all in front of you, and feel free to react to that and let us know if you feel like that still captures what you think is appropriate. Laura, I'll go to you next.
Thanks, Jen. I was thinking about lowering my hand, but I guess I have questions about, is this substantially different than what we do now? Do we think it needs to be substantially different than how things work now? Do we think that there's additional risk of gaming with AI, especially levels of AI, saying, using AI and ambient dictation initially to create the record and then AI for abstraction on top of that? Um, and then I also had just sort of a general scope question, but I'll kind of leave that one.
Great. Thanks, Laura. I would say, and welcome other folks on the line, both from the team and the TEP who've done measure development before. I do think that the way we've described this perhaps goes one step beyond what developers currently do. In that we certainly, when I've developed measures, we certainly think about gaming and try to construct the measure in a way that makes it as least gameable as possible, but there's no requirements that I'm aware of for developers to sort of document that and share it with the program owner. You'd certainly want to be able to defend your measure, but it's this documentation and the research described here and using particular metrics or something like that. I don't think that's part of the current process, at least in my experience.
Thanks, Jenna.
But I think like as part of the evaluation, right? If you didn't design it properly, I mean the stakeholder will raise the question, so may challenge the validity or reliability of the measure. I do think AI, because of complexity, it does create additional area, right? May create a problem. Now in the past, sort of when you talk about process measure, discharge, coordination, disposition, and some healthcare systems have better infrastructure, and they can just they pre-make pre-made a documentation, check it out as if they're doing the work, right? I can see that you can extend to AI. It's sort of they figure out a way to generate something, but doesn't truly reflect what happened on the ground. So
Thanks, EQ. Yeah, like it definitely needs to be something that's been thought about. Paul.
Yeah, I was going to respond to what Laura said. In theory, it shouldn't be any different with AI, but this is a new world we're entering. And so she raised the example of the ambient dictation, ambient scribes. Actually, that's where the hallucinations come in. It's hallucinating both to increase the reimbursement, and as Ziku mentioned, it's supposed to only talk about things that happen in the room, but the hallucinations are talking about things that didn't happen in the room but would increase your reimbursement or increase your quality measure. And that's the problem. So it's really become easier to outsmart and to take advantage of this technology to create higher reimbursement and higher quality scores, unfortunately. And that's I think what we're trying to do is put the guardrails to try to tamp down on that.
So there's a layered concern. Something we need to kind of, okay, thanks, Paul.
Unfortunately. But that's what our report is supposed to do, is to try to get ahead of it, and try not to let it happen, because there's always a motivation and incentives to do the different.
Great, thank you all. So I don't think I'm hearing anyone advocate for taking the report in a different direction or re-editing what we've already provided. Am I hearing that correctly? Does anyone think there's anything we should be revising in the report based on public comment?
Maybe what the program owner suggested, which is having standards for the measure developers in terms of measure anti-gaming or gaming prevention. And it's like you said, Jenna, we haven't asked them to sort of disclose how they thought about this, and why is this data element better from a gaming perspective, or a more honest and reliable reflection of performance. That kind of thing can just sort of raise the tide, raise the bar for everybody.
Thanks, Paul. So I'm hearing one suggestion to, if we don't already have it, and I don't remember, I'm making it more explicit for the program owner to set standards related to gaming. And by standards, I think we might mean just being clear about what the developer should do related to gaming. That would be the one addition. Do others agree with that? Does anyone have concerns about us adding that?
I don't think it would hurt.
Okay. I think I wore you all out. Or you're all, these are simpler topics, so maybe easier. The latter is the case. All right, I think we can move on then. We're getting back on schedule, and I think we could just keep going through our agenda then as we have it. So I think then, if I'm right, the next one's promoting interoperability and use of data standards. Great. Okay. So we received 6 comments on how to promote interoperability and the use of data standards in the report across 5 unique submissions. Related to strategy 2, one professional society recommended AI-enabled measures leverage existing clinical documentation and workflows to avoid duplicative entries. Similarly, the same group suggested outputs should seamlessly integrate into EHR dashboards, alerts, and tools. A different professional society noted that for data to be used across multiple programs, outputs should adhere to open standards such as FHIR. Another professional society recommended leveraging established outcome standards such as FHIR, SNOMED, and LOINC-based outcome measures to promote interoperability. Related to strategy 3, a consensus-based entity suggested feasibility assessments assess infrastructure readiness by evaluating data availability, interoperability, and computational capacity. So what we would be focused on there is the idea of the feasibility, including interoperability. And then strategy 5, to support monitoring and maintenance activities, a government policy group suggested leveraging open source technologies or platforms such as FHIR. And there's some others listed there. I think some TEP members have we've heard a comment or two about this before from a couple of comments from the TEP, and but we haven't had significant discussion about how AI enabled measures and the outputs from those AI components would fit in with data standards and structured fields in the HR, things like that. So is there anything that you would want to add to the report related to either interoperability or the use of data standards based on these public comments, or again, your own expertise and things that you've thought about before? And then if we want to add anything, we just need to make sure that we identify who the responsible key actor is. So I will stop there and see what the TEP has to say related to this. Start with you, Laura.
I love the idea of promoting interoperability and standards. I think that's a great idea. I love a world where in the future we have this information and it's available for further development and getting it into the public domain and being able to use it in other ways that are helping people make their own decisions about their own healthcare at a detailed level. I think that's a great vision. The one I in some ways I want to push this further, in other ways I want to pull it back a little bit, like the AI-enabled measures, leveraging existing clinical documentation and workflows. Some of our workflows and documentation are really messy now. I hope that they actually improve these things. I think I see what they're trying to say as far as not being disruptive, but I hope that in the future they are disruptive to a point of making things easier, and clearer. Um, the feasibility assessments, infrastructure readiness. Can we talk a little I didn't dive into that one deeply myself, but can we talk about what they're thinking about? Are they looking at the measured entity, looking at their capacity, et cetera, as feasibility? How far do they want to take that piece?
Yeah, great question. So I've asked the team to pull the public comment and put it in the chat. So it might take a second. I appreciate those comments. And if we're getting support for adding this, I definitely think we need more discussion about what we're actually trying to say in the report, because some of these are somewhat vague. But appreciate the support so far. I think you started pointing out things that we could put in, Laura. John, I'll go to you, and then Laura, we can circle back to you once we've put the comment in the chat.
Yeah, like Laura, I mean, I'm supportive of interoperability. I think it's great, and if we can do it, make it more efficient, and that's fantastic. I guess one of the things on this that stood out to me is the output should integrate seamlessly into EHR dashboard alerts, tools, and actionable in real time. I mean, I think some of that we may be putting too much burden on like measure developer or any, it depends on who's expected to do that, I guess I should say, because if they have to develop something for every dashboard that's out there, that's just a bit ridiculous, I think. But I do think again, interoperability as much as possible would be good for efficiency's sake. And I think using the standards that are out there today as much as possible, that's fantastic as well. And um, you know, I'll leave it at that.
Great, thanks, John. Okay, and I'll start asking the TEP as well for just what are the concrete things you want to add? And again, I do think we have to identify the key actors as well. And Emma, thank you for adding the comment that Laura was asking about into the chat. Vinny, I'll go to you next.
Yeah, I think I'm gonna agree. I think the supporting interoperability in general, good. I agree with John that the seamless integration into EHR dashboards, like that's great, but not, I don't think that's necessary for quality measures, like because it's not individual clinicians who are actually, evaluating these outputs. So I don't think that, I think that's a step too far.
Great, thank you. Okay, so Danielle, go to you next.
Um, so interoperability is sort of like motherhood and apple pie. You can't really be against it, right? So like, sure, we should have it in there, but to John's point, it's like, well, who's doing what, right? The devil's in the details. I think part of the issue is that a lot of interoperability right now is about fundamental national infrastructure that's not there, right? So you have to have the pipes laid through things like APIs, and you have to have things like directories of provider and payer endpoints, and things that aren't there on a national basis that no one of these actors in our categories of actors is going to be able to single-handedly solve, right? So I think we have to be careful about exactly what we're asking for and whether or not this is in the like future bucket or a recommendation for today. One thing I will say, something that AHIP supports as well as the Core Quality Measure Collaborative, is the notion that as you're building new measures, trying to use elements that are in the U.S. core core data for interoperability, or US CDI, as sort of the fundamental building blocks, because then you can build fire-based measures that have explicit standardized value sets and such underlying them. So any use of standards, whether it's exchange standards or content standards, I think is a great, like that's something we could recommend and can be done at a measure developer level. But I think we have to be careful to suggest anyone's going to be able to, connect into and push in anything into a particular EHR, right? I think that's where we get to the sort of bridge too far.
Thanks, Danielle. Yeah, and again, like I'm going to ask the TEP to get a bit more concrete because I do think, yeah, supporting interoperability, like yes, we all want to do that, but what exactly does that mean? I guess one of the questions I have for you all is I mean, we've been talking as an example a lot about using NLP or LLMs to pull unstructured data. And in some of those cases, there might not be standards to support those data. For example, you might use like I'm just imagining you could use NLP to identify worsening pain. I'm fairly certain it's been a while since I've looked at SNOMED. I don't know that there is a code for worsening pain. So are we saying you shouldn't use that? And are we saying that the outputs then get mapped to existing codes and terminologies? I'm just trying to really try to get more concrete about what the recommendations are here and what the TEP wants to put in the report. So see a few hands. Laura, I'll go to you next.
So I think the idea of having EHR-based dashboards is awesome. Having information at the point of care to understand where you are as an individual in terms of quality scores, knowing what care gaps you need to address and how you do those effectively, getting the right data from payers in real time around assigned populations and assigned but unseen to be able to close gaps is critically important in the long term. And the only way to do that is through interoperability. Um, Certainly mandating that you do this in a way that integrates with every single EHR off the, on the in the market right off the bat isn't feasible. But as a long-term vision, I think that's how we're going to make things more effective than having to look at different portals, payer portals, EHRs, you know, uh, third-party quality systems, and kind of have this really fragmented database that we use to try to drive towards quality. So I do think it is a really good end goal. Um,
Thanks, Laura. I wasn't sure you were done with that thought there. I will go to Monica next.
Yeah, I mean, I think the point you bring up of if it doesn't map to an existing SNOMED concept, should we say it can't be one? And I would agree that so I did a lot of SNOMED study in my first 2 years of the PhD, and it was a lot of oh no, this is a pretty messy terminology because I think a lot of it is what someone chose to sort of decide to put into SNOMED. It's not like a very I think there are certain areas of SNOMED that are super fine-grained and very exact, and other parts that are just less explored, and it was based on who happened to kind of add in some of those terms. So I do think SNOMED is one where I would agree that for NLP pieces, I would feel a little iffy about saying it had to map to something in SNOMED.
Thanks, Monica. I wonder if this is a topic that maybe belongs in our future considerations section, where we can describe the conversation you all have had and said it's something that is something, it's still work that needs to be thought out more as AI evolves. Because I certainly, as I was trying to indicate, I also wouldn't want AI if it helps us find better data or more informative data. I wouldn't want to say that it has to hold it back. I don't know what you all think about that. So it could either go in our future consideration section that we're going to add to the report or emerging topics. So what I think maybe future considerations. What do others think? And that would mean we can still describe the discussion you all have had. Chandra, go ahead.
Yeah, I think I would say future consideration because when we're talking about interoperability is changing, right? Where we have went from standard HL7, now we're looking at Fire, folks are using APIs. So there's a lot of change that's happening in there too. So to directly point it out. And there's also the talk of AI being able to utilize AI maybe helps with some of that also to where you won't necessarily have to look at the interoperability standards because we have AI to be able to go in and use natural language processing to mine notes and things of that sort. So I think I think maybe looking at future consideration and just say, that it's something that we'll look at in the future. I think that's good enough and it's mentioned. So
Great. Thank you, Chandra. Megan.
Thanks. I just want to voice support for that as well. I think this is something we all support as a future goal, and it would be amiss, I think, to not mention the resources that are available in the off chance that someone reviewing the report isn't aware of things like USCDI and these structured terminologies. But I would also agree with Monica's characterization of them. They're much more built out in some areas than others, so limiting to standard terminologies, I think would be a big challenge. But I think pointing to the ongoing landscape of interoperability work and how contingent quality measurement is, especially as there's more AI derived components, is going to be on interoperability would be important in future work.
Great. Thank you, Megan. Rosemary.
I support putting it in an emerging future category as much as I've spent a good portion of my career with standard terminologies and everybody agrees we should use them. Operationalizing it, I think, needs some vetting out because you have the interplay of quality measures, AI, user interface terminologies, many of which are coming directly from patients now. And then the mapping to reference terminologies probably requires a little bit of a deeper dive and a discussion.
Great. Thank you. And Laura.
Thanks. So what I'm seeing happen now, which I'm concerned about, is payers asking for all the data in supplemental data feeds. They want as much information as humanly possible. Um, and and we do have evolving interoperability standards. We do have issues with privacy and security. We do have issues with managing consent, especially where some of our interoperability includes organizations that aren't HIPAA, but maybe they're, community benefit organizations or they're 42 CFR Part 2 organizations. And we have all sorts of data that's out there in the community. So I do think, again, we need to kind of push towards this, but I would also want to make sure we're mentioning some of that additional complexity because we need to get to a place where we have just the right amount of information shared to meet the measure and not these broad sweeping massive data dumps of personal information into third-party systems or additional environments and having, additional kind of intermediaries created at high cost. But again, I do think that getting to a level of integration and real-time information is going to improve transparency.
Great. Thank you, Laura. I think we can reflect that as well, unless anyone has any concerns about that. You all have shared some great thoughts that I think we can put into our future considerations section. All right, thank you all for sticking with me. I think we just have a couple more topics, and then we'll see if there's anything else that you all want to raise. So the next is about refining some details in the AI model summary label. And we did pull out some specific things that we think are more have some higher level implications. So we did receive one comment from a public-private partnership about clarifying how developers should complete the summary label for measures with multiple AI-derived components. Specifically, the commenter asked whether these measures should complete the summary label for each component or the entire solution. They noted that describing each component separately could become difficult to scale and may place burden on developers and on entities that need to validate each component and the measure itself. The same organization also provided comments related to clarifying the development and testing section in the summary label. They noted potential challenges about sharing the number of patients, records, and data points, especially if an AI-derived component uses foundation models. They further cautioned that the definition of a data point can be highly variable. For example, it will fluctuate for models that are continuously learning, like Gen AI-based solutions. We also received 4 comments across 3 unique submissions about including additional fields in the AI model summary label. A consensus-based entity noted that to enhance utility, the label should include versioning and update history, enabling the stakeholder to track changes over time and assess the evolution of the component. We do already have a field in the summary label for the version, but I don't think we're currently asking for things like what's been updated since the last version or an update history. The same group also recommended that the label incorporate recent auditing information. A professional consulting service for payers, direct care, and government agencies suggested an additional qualitative indicator tied to a pass rate or risk that might make it easier for users to interpret the reliability of the model. And an individual commenter recommended that the model specify updated cadence, triggers for revalidation, and oversight for modifications that could impact output behavior. So is there one question we do have is, do you have any thoughts about how a measure developer should be completing the summary label for a measure that has multiple AI drive components? And I don't think we have an example of that yet. But if you have thoughts, feel free to share those. And then is there anything in the comments reflected on the previous slide that you'd want to include in the report or that you want to discuss? So we can go back to the previous slide and see what thoughts you all have here. And especially, so going back to the question, if there's a measure developer with multiple AI derived components, would you picture them filling out the entire label for each component? Would there be certain sections they'd fill out for the entire measure? I think at least on the staff side, we were picturing that this would be for each component. And again, I will say in the future considerations section that we're going to talk about next, we do think that one of the things we'd be recommending in the report is, because we heard suggestions for this in public comment, that we need some additional, it might not be part of this work, but it would be great to have some additional examples completed in the summary label and sort of vet the summary label more, pilot it and see how it works. So this could also be something that goes into that part of the future considerations where you say additional thought would need to be given, and it might be best to do with an actual concrete example of what it looks like when there is a measure with multiple components. Okay. Okay, go ahead, John.
I'll just second what I think you guys were thinking, as each component should be at least called out and identified, described. Yeah, just seconding what you said before.
Sorry, it took me a second to unmute there. I think if we were to, again, we could acknowledge that this is something to investigate further in future considerations, because I think that would be a lot for a developer to do, and maybe there are some places where efficiencies could be introduced. But again, it's hard to think about it, I think, as well without a concrete example. Monica, go ahead.
Maybe one thing to try to just wrap my head around and clarify, less so than a comment, is like, let's say there's like a past medical history section of the measure, because I know a lot of the times there's exclusions based on having some past medical history. If there's like, 15 of those variables, do each count as a separate component, or would it be like one so I think I think there was also something somewhere about granularity, and I know this has come up before. Because I do think like, probably it would be a lot to sort of fill that out 15 different times, especially if, because I think a lot of quality measures right now require, you know, very large number of variables.
Yeah, I think that's a good question, Monica. I don't know if anyone on the TEP has reactions to that. All right, so I imagine people's energy is might be flagging a little bit. I won't say for sure, but I know we've been taking your lunch. It's a 3 hour meeting. Those are tough. So we can take this offline and think about it a little bit as a team, and perhaps even reach out to you all about this, because it might be something that we want to at least try to clarify. But we can work on that a little bit offline and reach out to you all. Again, I am recognizing that a 3 hour meeting is tough. So why don't we move on to the last topic, which is letting you know about this future consideration section we've mentioned. And we've pulled out some topics that you all, that I think came up in discussion on Monday, and that we also saw in TEP's feedback on the public comments for those of you who shared some feedback with us ahead of the meetings. So these are some of the ideas that we were thinking, and we definitely welcome you all to share thoughts with us offline as well, if you're reviewing the public comments and you think there are topics that we didn't discuss but are really important that should be part of a future consideration. So we have here the idea of risk tiered monitoring that may be, again, to help address some of the burden issue that perhaps and we didn't talk about it much, I don't think. And it is a part of AI standards that we see and other governance documents or standards, that the amount of oversight you're applying might depend on the amount of risk. So I think that is a great idea. And again, something that we're not going to have time to tackle with this TEP, but how might the recommendations get applied, or how could they vary depending on the level of risk with how you're using AI in the measure. We also, as I said, there's some calls in the public comment for there to be additional vetting or use cases for the AI model summary label. Monica, I know you've raised the point, and I think we've also heard that we haven't had time to really dive into a lot of different types of AI use, and think about how the recommendations might need to be adapted for different types of AI. And then there were calls for in the public comment that there needs to be some infrastructure and continued work on the recommendations themselves. I mean, these are certainly not recommendations we can put out once and they'd never be touched again. They'll need to evolve as AI evolves and as the field of using AI and quality measures evolves. So we can leave this slide up, and I'll just ask, do you agree with these topics? Do you have any concerns? And are there any other topics that you'd like us to add to the future consideration section? Okay. Not hearing any concerns or immediate suggestions for other topics, but as I said, if you have thoughts offline, please feel free to reach out to us. And then before we wrap up, we just want to see if there are any other topics any of you would like to raise that you feel like we haven't touched on that and you think we should have, either in your own review of the public comments or things over the course of our time together that you think we need to discuss one last time. So we definitely wanted to make sure gave you all an opportunity to share any last thoughts. Paul, go ahead.
Maybe this comes under the original, what's the purpose of the report? Who's going to watch over these things going forward? I guess you're under Joint Commission. Do they have a task force, or how are you going to decide how to employ AI methods in quality measurement in the future?
Yeah, as we said at the beginning, Paul, we don't have an immediate pathway for that. I mean, certainly things within Joint Commission, that's something that we talk to our colleagues about, but I think we don't have an immediate pathway as far as either updating the recommendations or ensuring they're used. I mean, also when we release the report, we will engage in some dissemination activities and talking to interested stakeholders about the recommendations. Elizabeth, I don't know if you have anything to add.
I'll just add this, this is a funded effort funded through the Gordon Betty Moore Foundation, as you know. And so it's a discrete convening. We really want it to be impactful, so we're engaged with a lot of others in the environment to make sure it gets out there. In terms of maintaining it going forward, that's TBD. As Jenna's saying, we don't have any current plans, but we have the intent of everything we do of not just putting a report on a shelf, but continuing to make sure that it has impact. These things are coming up all the time in our routine work as measure developers and measures users across, both NQF and the Joint Commission. And we will be in dialogue with others about it. But I think if you're asking, Paul, do we have like another future step in this report? Great question. It's something we can think about, but we're we're focused on wrapping this step up right now. And we don't have a specific plan for that.
All right, thank you.
Any other topics or questions? Rosemary.
Yes, going just to dovetail on what Paul said, and it may have been discussed already. I apologize. A couple meetings I had to attend. In terms of recommendations, has it been discussed to integrate some of this in? Because there are a lot of initiatives underway, and this work could be leveraged to harmonize with some of the other initiatives that are going on at a national level for quality measurement, for AI in general, and maybe some sort of recommendation to do that. I think it would be helpful.
Yeah, I can say that my impression right now, and I don't have my eyes on everything, is we actually are leading in the sense that this is a specific use case, and we are taking, as you know, recommendations from others, National Academy of Medicine, NIST, CHI, FDA's frameworks, and applying them here to this relatively narrow but still broadly, and it engages a lot of parts of the healthcare system, and it's a use case that has a big impact. You can see from the comments that hasn't been done like deep dive like this that I know of, in this kind of a space. And so we have been engaged from the beginning with other organizations like NAM. They're one of our Jenna, you can use the right term. They've been observing and participating in some of these meetings. AHRQ, others are on the phone that have been active in these spaces. So, that Chai, others. So we're not trying to move separately from them. And then the users include, again, organizations that help set consensus-based standards in multiple contexts. Here in this discussion in our organization, the CMS-funded consensus-based entity for endorsement and selection of measures for CMS regulatory programs. That's why Danielle talks about it. There's a lot of conversations going on among health plans and the Core Quality Measures Collaborative. So we're aware of and trying to be in dialogue with these and make sure that the report is visible. We flag it for all those types of organizations so that they would attend to and respond in public comment on this particular application in quality measurement. If we're missing organizations that are active, please let us know, because we do want to be as inclusive as possible in our outreach and engagement. And some of you may know, and feel free to put them in the chat or email us later if you think there are efforts underway, again, particularly in the context of quality measurement, that we just haven't been aware of.
Yeah, and I didn't mean to imply that it's not been up to this point. I was thinking as the nation and all of the entities that you identified, everybody's moving forward and things are evolving, and it would be nice to have, because it's such a great body of work, and it's applicable for not only formalized quality measurement, but performance improvement within health systems. So to I guess keep it alive and continue some of this integration. And I think I'm now probably repeating what Paul said. I was trying to support the case and take a different angle at it, but if there's something that could be put in the recommendations for the future, I think it would be good.
Great.
Yes, thank you both, Rosemary and Paul, for raising that, and so glad to hear folks would like to see the work continue. I know. All right, well, why don't we go on to next steps then? Thank you all again for the great discussion today, on Monday, for the work you've done in reviewing public comments. I'm not going to I have more thanks to share, but let me focus on the next steps first. We might be reaching out to you individually or small groups, or reaching out in some way as we are writing up the final version of the report. We will share the recordings from both web meetings as well. And as we said, we'll be refining the report and editing between now and then. We'll give you an opportunity to review it. I think we're aiming for early to mid-February. So you'll see it then, and we'll want your feedback then. Those are the next steps. So let me move on to some closing remarks. I have been lucky enough to be involved in this work from the very beginning. And as a reminder, our first meeting was January 23rd of 2024. It took us some time to sort of figure out how to tackle this really complex topic of looking at the use case of quality measurement and thinking about how to bring together existing requirements for developing, testing, and implementing measures with emerging guidance around AI governance and monitoring. And I just really appreciate, and I know our team really appreciates you coming on this journey with us across 9 web meetings and in-person meetings, and then some small group discussions we had in our first year. You all have been just so engaged and thoughtful at each and every step. Every single conversation we have with you, you all are engaged from beginning to end. So on behalf of myself and the team, I just want to say we're truly thankful for the time, expertise, and contributions you've brought to this initiative. I would also like to thank our team, who are always working in the background, doing so much work for their dedication and commitment. They've done a truly impressive amount of work preparing for each meeting and drafting several iterations of the first version of the report you saw, and they'll be working on making the updates. So I really want to thank them. I want to thank Elizabeth for her leadership on this. Again, this is at the beginning, Elizabeth and I had a lot of conversations about how we could shape this, and I'm just really happy with where we've ended up. I hope you are too. And Then I wanted to say, I know this is our last meeting, but our collaboration does continue from here. We're looking forward to keeping you informed and engaged throughout the next several months as we prepare the draft guidance or final guidance and recommendations for publication. And Elizabeth, I'd like to turn it over to you for any closing remarks you have.
Thanks, Jenna, for your kind words. And one of the joys of this project has been working with Jenna and our whole team at NQF and also all of you. So I just want to add my personal thanks and on behalf of NQF, all of our thanks to you, to our funder, the Gordon and Betty Moore Foundation, also to the staff from the Joint Commission who've been resources to us at times during this project. You know, these consensus processes are challenging, and we deliberately, as you know, recruit multi-stakeholder groups with diverse experiences and opinions. And I really want to thank you for how you work with each other. You brought your own viewpoints and detailed experiences that have been super helpful for us reaching a common understanding of the issues that we need to grapple with. And then you thoroughly listen to and learn from each other. And it's really that that has allowed us to get to a consensus-based report. I know we have a few words to work out still, but just really want to thank you for the way you worked. I didn't realize we'd had 9 meetings, including the in-person one. So, and the length of your commitment to this continuity of the discussion where we've been able to build consistently on the prior work we've done and keep moving forward. I hope you feel the work is valuable. I was really struck in the comments that there are a lot of others, as you can see, wanting and needing this type of foundation set forth so they can begin to work to move AI-enabled quality measures forward. And I think we've made a major contribution here to the field that will allow us to take that step to move measures, at least start to take that step, test, iterate, and improve to lower the burden of measurement and also our North Star, which is to improve the quality of care for the patients we serve. And finally, or not quite finally, second to finally, I want to thank Jenna for what she has done. She's masterful at this, as you can see. She makes it look easy and she guides us through very difficult conversations. Today's was a case in point. The prep that the team does also really serves us very well. So I'm just going to pause for a moment. Thank you. Yes, please join me in applauding her professionalism and leadership and skill. And then I'll just close by saying, I personally, and I really enjoy just getting to know those of you I already knew better and to getting to know new people here. We want to further our relationships with you and engagement. We hope, you're more connected as a series of experts who deeply understand the challenges and the opportunities. And so this isn't like a goodbye. We will continue to look for opportunities to stay connected with you even after we finish the report, so that we, as a group, all of us can continue to contribute to the field. So thanks again for all that you've done, which has just been a substantial and impactful body of work.
Thank you so much, Elizabeth. And yes, thank you all. We look forward to the last few steps here and getting to a report that I hope we can all be proud of, and that really helps move the field forward. We will certainly be in touch. And if you do have any thoughts after these meetings, please do feel free to reach out to us. So we'll see you in email and look forward to our continued work together. Thank you all so much.
Thank you.
Take care.
Thank you.